infratemporal fossa, or if serious minimal ethmoidal disease and a complete orbital apex involvement presented with blindness. And this was chronic invasive fungus. So this is a different variety you should be able to pick up pre-operatively because it is the right diagnosis which can take you to the right treatment line. Reason being, in non-invasive fungus, antifungals are not needed. Fungal mycetoma, allergic fungal sinusitis, antifungals have no role. But in invasive, here the treatment is different. You are not supposed to remove this fungus completely. Unlike allergic fungal sinusitis, where every fungal antigen, fungal particle has to be removed, that is serving as an antigen. Here, like this, even in spite of here, you don't need to remove this entire fungus. Once you suspect chronic invasive, the role of surgery is limited to confirm the diagnosis that the fungus is invading the mucosa. Just a biopsy. If some sinus is blocked, establish the ventilation drainage of that particular sinus. And once the diagnosis is established, medical treatment is the answer and the voriconazole is drug of choice. That can kill this entire fungus. You don't need to remove this entire thing. It can clear all this very fast. So this is chronic invasive fungal sinusitis. This is a different fungal disease. See this, the sinus involvement is less, but the extra sinus disease is more. I'll give you an example with additionally help from the MRI to direct more specific treatment. See here. See this patient. See this patient. See this patient. He had, now we have proven with the biopsy. He came to us with this picture. We took a biopsy, suspecting chronic invasive. Turned out to be chronic aspergillosis, started voriconazole, now everything subsided. You don't need to remove anything. Don't frighten with the intraorbital, intracranial or anywhere involvement. You don't need to remove anything. Just open up the sinus. We opened the ethmoid sinuses, established their drainage. You know, the frontal was already draining, on the ethmoids were obstructed. And and then once the diagnosis is established, voriconazole has to be given as a treatment of choice to treat such patients. So chronic invasive is a different entity. Now finally, the most important entity we have discussed a lot during the COVID times is the acute fulminant fungal sinusitis, commonly known as mucormycosis.
Sir, for how long voriconazole has to be given?
Yeah, so that's a very difficult decision, but yes, that decision has to be taken on 3 grounds. So it has to be taken on 3 grounds. Number 1, the radiological grounds, if the fungus is completely subsided. Clinical grounds, if patient is no more symptomatic. Third is biochemical grounds. You have to, once you are treating, before you start the treatment, we get the galactomannan test done. Galactomannan is a protein found in fungal cell wall, aspergillus cell wall. And before you start treatment, you can, at the time of biopsy, with this biochemical test, you can prove that this is chronic aspergillosis only where the galactomannan levels are high in the serum. And then with the treatment, you can monitor the galactomannan level. So the third is a biochemical, the galactomannan and the inflammatory markers like ESR and CRP, they come down. ESR is more informative as the CRP denotes bacterial infection, which is not there. So when everything comes down, clinical, radiological, biochemical, you can take a call. Sometimes you need to give 4 months, 6 months, 12 months, 18 months even. It depends. And you have to monitor with the liver function test. In certain percentage of cases, it is hepatotoxic. We have seen patients dying with a voriconazole because of liver failure. So you have to be very, very cautious about it. The fourth variety is this acute fulminant, that is mucormycosis. It's a different endotype, presents in a different way, very fast presentation as it invades the vessels preferentially. What shall we get on it?
Sir, can chronic invasive convert into acute one at
Not
any
really.
stage?
Not really. That's a different
Different
pathogen.
entity.
Different pathogen.
Okay.
This is the pathogen in mucormycosis, belongs to the zygomycetes family, is a different one. And it preferentially invades the vessel and blocks the vessel, giving due to thrombogenicity, it invades the vessel and give complications because of the vascular blockage, because of the ischemia to the finally to the tissues, and patient present with those problems. And see how you can pick up right from the diagnosis till final answer, till treatment, the thing which can guide your treatment thoroughly, perfectly, is the MRI, contrast MRI. For two things. Number one, for diagnosis. You see the area which is necrose, which is not picking up contrast. See the opposite side taking up contrast, but see the turbinates, and this area which is not taking up contrast, that itself gives you the diagnosis. Number one, that this is mucor, which is given vascular necrosis. Number two, it dictates your surgical, extent of surgery. It's a medical disease, invasive fungus. Ultimately, treatment is medical, and here the treatment of choice is amphotericin B in liposomal form. But in the necrotic areas, amphotericin is not going to penetrate. If the gadolinium is not penetrating, amphotericin is also not going to penetrate, because it has to go through the blood only. If there is vascular necrosis, vascular occlusion, thrombosis, where the gadolinium is not going, your treatment is the medical treatment is not going to be effective. So the extent of surgery is guided by MRI, contrast MRI. Wherever gadolinium is going, even if there is fungal infection, the liposomal amphotericin will kill. But in the necrotic area, you have to debride as soon as possible, because this is the depot of fungus now. That is the environment which invites more and more fungus, and it's going to give further complications. So the MRI will tell you the extent of removal. See, in this case, even the septum has gone, septum had to remove, even sometimes the soft tissues have gone. If you leave the necrotic area behind, the medical treatment is not going to be effective. So this is something must keep in mind. The extent of surgery should be dictated by MRI here. If you leave any necrotic area, it is going to progress. See this example, we lost this patient. As a patient had a good vision, so we didn't treat the eye, and the eye had necrotic area, lot of necrotic area inside, and later patient presented with vision and cranial complication and died ultimately. So even if you have a good vision, if you find necrotic areas in the eye, maybe still the vision is intact, you have to treat it. It's not the vision as compared to the life. Life is more important. So see this particular patient, see when it invades the soft tissues. Now the soft tissue from outside appearance may appear normal, but yet showing necrosis inside. So if you don't remove, you see this nasal ala, soft tissues, all have to go to give this patient to make this medical treatment effective. If you don't do that, you cannot cure this patient. So the
Sir,
MRI,
this is gadolinium MRI or?
yes, gadolinium enhanced MRI.
Okay, sir.
See this, the entire orbit is gone. You have to debride it. Anywhere fungus is there, see this fungus, you can remove all this entire maxilla, you can remove. But see this, the greater wing of the sphenoid, it is gone, and you have to remove this greater wing of the sphenoid. So this is very important to address all these issues. Uh, so, in mucormycosis, the treatment is entirely dictated by MRI. We have more than 800 MRIs from the mucor patients during that time. You know, with variety of funny presentation, and MRI was life saving to them. Quickly giving 2 or 3 examples, as somebody asked me in the dinner last night to tell something about the MRI. Sometimes you get a patient suspecting mucor. See this. This patient in mucor, the sequence which is most important is the fat suppress. I tell you the reason why. This is very important to understand. This is T2 weighted MRI. See, one side is normal T2 weighted, one side is T2 weighted fat suppress. What is difference? You suppress the fat. Suppress the fat on this side. Here the fat is appearing as a bright. Inflammation also appears bright. Now, how can you differentiate whether it is a fat or inflammation? On this side, this is fat suppressed. Now, whatever appear bright is the inflammation. See now, in this is sphenoid sinus. That's the posterior part of the nasal septum. Now inside the sphenoid. And see now, even in the pterygoid region, infratemporal fossa, wherever there is hyperintensity, this is pterygoid process. This hyperintensity is all inflammation. Here you cannot differentiate in a normal T2 whether there is fat or inflammation. So T2 weighted MRI. This patient had normal endoscopic finding, diabetic, no other presentation, some pain, vague pain. We got the MRI done and see the entire septum has gone. The sphenoid was full, pterygoid was full, infratemporal was full, and it was mucor. MRI can help you reaching the early diagnosis. There is no other way than MRI which can take you to the earliest diagnosis. This is a classic example. Let me tell you some of the classic examples how MRI can save you. This is something that even the radiologists, do not tell you. That they don't have time to go to that depth unless you ask. Now see, I am giving you certain classical diagnosis which can really help improving your diagnosis. See, this is the patient. This was again a lesson to us in the early phase. This patient had mucormycosis. Unlike other mucor, this was treated on the ground of mucormycosis. Again presented with the persistent problems. Then we got the scan done, reviewed the previous scan. And an interesting finding was what we missed was the early palatal involvement. See what I'm trying to say. This is fat suppress MRI. On fat suppress MRI, in the bones, there is bone marrow which is fatty. On fat suppress MRI, it suppresses the marrow. See this, like this is T1 weighted. Can you see the marrow? Which is hyper intense. T1 weighted shows wherever the fat is hyper intense. See this, wherever the fat is hyper intense, wherever the bone marrow, it is hyper intense. See this, T2 weighted fat suppressed, the marrow will not be suppressed. See the early alveolar involvement. Normal side, marrow is suppressed. Marrow is suppressed on both sides, but this is inflammation. This was the earliest involvement by the infection, mucor, which was not apparent on the surface of the palate. And later on, we presented with a surface lesion. We reviewed the previous MRI and we missed this finding and had to undertake a second surgery. So early palatal involvement you can pick up by means of a good fat suppress MRI, it can, help you pick up the early lesions. See this patient, fat suppress MRI. See this massive involvement of the infratemporal fossa, bilateral involvement of the alveolus. We had to remove the upper alveolus bilaterally. So your fat suppress MRI can tell you exactly what is happening. Take into account the T1 weighted. T1 weighted, what will show you? T1 weighted will show you. See this. In this patient, let me show you a normal T1 weighted and normal T2 weighted, so as to differentiate what should be the normal and what should be the abnormal. A normal. I am showing you a normal MRI for this region. What should be seen on normal MRI? See this normal fat suppressed MRI. Normal, these are the turbinates. ये हिल गया कहीं से, देख कनेक्शन है लूज.